is not involved while putting the screws, and we can save the vertebral artery. After mobilization of the vertebral artery, bilateral C1 lateral mass and C2 pass screw were put under image intensifier guidance. C1 lateral mass and C2 pass screw, which is a classical technique to fixate for posterior fixation of the C1 C2 joints. After putting the screws, the rod was put between C1 lateral mass and C2 pass screws so as to fixate it. No spacer was used in this technique. So screws are being put on the bilateral sides. After putting the C1 C2 screw, after putting the C1 C2 screws, the C1 laminectomy was also done. 1 second, I think video. So the same thing being demonstrated, screws are being put and down, rods are being put on both the sides so as to fixate it, and we can reduce the dislocation between atlas and axis joint. And this is the final symmetry, and now C1 laminectomy being done to decompress the spinal cord so that the compression is relieved over the spinal cord. Post-operative course, patient was discharged on POD 9 and patient is neurologically same with 4/5 power in right upper and lower limb. Wound is healthy and having no discharge. So post-operative course was uneventful. Thank you. Thank you so much.
What is your opinion on laminectomy before placement of screws and before after placement of screws?
Sir, as far as I believe, if we do laminectomy before placement of screws, it can make spine slightly more unstable because of the spine, or especially cervical spine.
The whole idea is that the spine is unstable, that's why you're fixing. So if you put the screws before the in case you want to do a laminectomy and you want to put the screws, putting the screws actually makes it more mobile because you're manipulating the C1. It moves a lot and causes micro trauma. So what do you think about it?
Yes, sir. It can make the spine more mobile, but once we fix it with the rods on bilateral sides, there is some sort of fixation that comes in a particular position where the atlantoaxial dislocation is minimized, and once that fixation has been achieved, then if we do C1 laminectomy, it will be better for reducing the instability of the cervical spine and also to decompress the spinal cord.
The question was if you do a C1 laminectomy before putting screws, because while putting screw you will be pressing on C1 C2, so that will cause a cord compression as well. So whether you do a laminectomy before or after, that was the question, but it's fine. I mean, any other questions, Samir? Okay.
Thank you. Thank you.
We call Dr. Priya, the next presenter. She will be presenting a video on type 1 split cord malformations.
So, good morning, everyone. So, I'll be presenting on basically a case of type 1 split cord malformation. So, this child was a 3-year-old girl who presented with tuft of hair at back since birth, which was noticed by the parents. On imaging, there was a bony spur which was extending from D12 posteriorly. Basically, it was a ventrodorsal spur. And on the axial imaging also we can see these are the two thecal sac, the two cords, two hemicords, and then this was the split. This is at the level of the D12. This is the plain CT of the patient, which also is suggestive of the same. Here at D12, this is the spur, which is arising ventrally and then going towards the spinous processes. So it was type 1C Mahapatra and by Mahapatra and Gupta classification of type 1 split cord. So in this patient, the patient was placed prone and then the incision was marked from D11 to L2, and then the spinous processes and the lamina were exposed, and then the laminectomy was done using bone CUSA. This video is after the laminectomy was done. So here we can see this. Here, this is the site of the spur. So above the spur, there was some soft tissue which was removed carefully. After removing the soft tissue, the bony spur was delineated, and then using upcut, it was removed in a piecemeal fashion. Then again using dissectors, the bony spur was separated from the two hemichords and was removed using fine nibblers. So this is the bony spur which you can see very clearly. So here we can see it is present actually at the inferior aspect of the hemichords. So therefore it is type 1C classification. So then after removing whatever part of the bony spur we could remove, then the dura was opened above and below the spur. And then all around, at the level of the spur, it was open all around the spur. So here we can see this is the bony spur. And also we can see now the two hemichord. This is one hemichord, this is the other one. Then after carefully separating the spur from the two hemichords, it was removed in a piecemeal fashion. And here we can see that we have reached the posterior aspect of the spur. And then by carefully disconnecting the spur from the posterior aspect using a bone nibbler, the spur was removed. So this is basically a bone CUSA which is being used. So this is the last part of the spur which is being removed now. So that both the hemichords were free and there were no other tethering elements. So now we can clearly see the two hemichords here, and then using bone wax, hemostasis was achieved, followed by dural closure. And in this case, there was a low-lying cord also, so we had done detethering at L5 S1 level, and post-operatively patient had no deficits and were discharged on post-op day 5. Thank you.
Well presented, Priya. Any questions?
Among the splits, which do you think has the maximum chance of deterioration
Type 1D.
and why?
The type 1D, because in that the dura as well as the hemichords are they are closely adherent to the spur. So in those cases, when you manipulate the spur, there are more chances of deterioration.
Hello. Yeah, very nice presentation. Just want to know what was the post-operatively, was there any CSF leak?
No, there
Because-
was no CSF leak in the post-operative period.
Okay, because anterior dura, if we are not suturing very well, they could end up in CSF leak.
Yeah, basically, I think at the end I showed the bone wax was put, and I don't think there was any CSF leak anteriorly, intraoperatively also, as we could see.
Okay, thank you.
In this case, we didn't, and we don't usually, yes.
But do you generally tend to always close the anterior dura?
No, sir.
So we don't close the anterior dura. Normally it is recommended to close posteriorly. So you make a split into a single dural sac with both the hemichords inside. So that is the main idea, so that the tethering doesn't happen. In future, if they want to go ahead with a deformity correction, you have to do the split first, followed by deformity correction.
Okay, thank you, Priya. Next, I will like to call Dr. Dr. Tejas is there. Dr. Vedang. Dr. Anish.
Good morning, faculties. So I'll be presenting a case of Mr. A, 40 years old male, who presented with complaints of lower back pain and difficulty in walking since 2 years, complaints of numbness since 1 year, complaints of slipping of sandals since 1 month. On examination, the power in the lower limbs were 3/5, and the tone was increased in his lower limbs. On MRI, there was a D10 to D11 lesion with holocaust serings present for the patient. T1 hypo, T2 hypo, and T1 contrast, it was enhancing. Patient was planned for laminectomy and excision. It was diagnosed to be an AIIMS 12, planned for laminectomy and excision. Patient was placed in prone position. After laminectomy, dura was exposed, dura was open. This is the cranial, caudal, and the dorsal roots are visualized. Midline myelotomy was performed, and on myelotomy, you could see the tumor, which is visualized. And subbile stitches were taken to expose the tumor. There was continuous, they were using sharp dissection, the tumor was delineated, and dissection was started from caudal to cranial to separate the tumor. You could see a whole part of the syrinx present in the cord. Using sharp dissection, the tumor was separated from the cord, and there's a good plane seen between the cord and the tumor. On continuous sharp dissection, you could see on the cranial end, now we're dissecting on the cranial end. This is the part where most likely where the origin of the tumor could have been attached to the cells. So a sleeve of tumor was left behind, and then it was coagulated post that. Hemostasis, this is the tumor, this is the part where the tumor has been attached to the cord, and a sleeve of tumor was left behind, and then hemostasis was achieved, and then the pyre was closed. This is a part of the small sleeve which was coagulated, and hemostasis was achieved. Pile stitches were taken, and the pile stitches were closed, and then the dura also was closed post that. Post-op, patient was followed up after 25 days. Patient's power improved from 3 to 4/5, and the spasticity also had reduced. Thank you.
Thank you, Anish. There are several questions. I think we will take one by one.
So how did you identify the midline? Where to do the myelotomy?
So from the dorsal roots were present. So from there, the midline was visualized
How?
midway.
Huh? What are the two ways of identifying the midline when you're doing the myelotomy?
The dorsal medullary vein could be visualized. That will be the midline.
That's a question we frequently asked for you in your exams. So you better brush up your knowledge.
What you didn't use the inter neuromonitoring and inter ultrasound or the CUSA, these three things.
So the thing is, on that day, there was IONM was not available. So due to different reasons, it was not available. So we didn't use IONM at that. By sharp dissection, the tumor was separated, so QSA was.
So what was the histopathology?
So histopathology was grade 2 ependymomas.
And some tumor was left behind, right?
Yes. A sleeve of tumor.
So how do you follow up, and is there any requirement of adjuvant therapy?
So we follow up for every 6 months to check an MRI, get a check MRI to see if there is progression. Progression in size.
Progress in size then?
If patient is asymptomatic, we don't.
You reoperate or you go for adjuvant therapy? How do you manage if it recurs, increase in size?
So mostly we give
We would consider adjuvant chemotherapy following this. So probably we will be also having that in mind. But it was a very small lobule which was actually coagulated. So hopefully we will just first observe, and then if there is increase, then probably we'll consider. He actually presented with spastic paraplegia, almost. So just he had some power, so around 2/5. Any more questions? Okay, so last presenter. Is there a last presenter, Dr. Sarvesh Yadav? No, he's not presenting. Okay, so I think we are. Thank you very much, and we come to the end of this session, and I thank my co-chairs for being here on so early in the morning. We can move on to the next session. We close the session. Thank you.
Okay. So after this session, there would be a tea break. Then after tea break, we will start the case discussion for today's OTs. Okay. So there would be 15 minutes tea break. Then we will start the sessions.
OT-3 case 1. Okay. Good morning, esteemed faculty and colleagues. I'll be presenting the cases of OT-3, starting with the first case. Mr. X, who is an 84-year-old male, came with complaints of low backache radiating to the bilateral lower limbs since 8 months with a claudication distance of 20 steps. So he doesn't have any bowel or bladder involvement. His on motor examination, his power on the upper limbs is 5/5, lower limbs is 4+/5 at hip joint, knee joint, and ankle and EHL. Sensations are intact, tone is normal. Reflexes are 2+ in the lower limbs and plantars are flexor. On imaging, he has a multiple level lumbar PIVD with L2-3, L3-4, L4-5, and L5-S1 with listhesis. This is the CT of the patient showing the L5-S1 listhesis. I'd like to invite Professor Park for the operative approach to this patient. The pointers.
Actually, hello everyone, I'm Park from South Korea. It's my great honor to stand here. Actually, all of cases are very severe and complex case, but my case is very simple. Just only spinal canal stenosis on L4-5. So today, I would like to have a live surgery. How can I decompress the spinal canal stenosis with the endoscope? There are two types of endoscope, unipolar and bipolar. Today, I want to show you how to decompress the spinal canal stenosis with usually I use the epidural anesthesia, and my operation time is around 30 or 40 minutes. And this case is a very severe case of spinal canal stenosis. So I'd like to remove the ligament flavum with one piece or two piece. Usually, if you remove the your ligament flavum with a piece by piece, it is some cause of early dura tear. I mean, endoscope is a water-based surgery. Microscope is air-based surgery. So laminotomy, usually laminectomy and proximal ligament flavum, laminotomy, proximal ligament flavum make early exposure of epidural space. It means if you expose epidural space early stage, it can lead to the early tearing of dura. Early tearing of dura means you have to convert your surgery to the open, because the pressure of your surgical field is transmitted to the intracranium because we are operating in the fluid. So, I mean, the late exposure of epidural space, it means after completing your drillings, laminar drillings, full drillings, and the exposure of your ligament flavum, especially for the inner layer of ligament flavum, and separate your ligament flavum, and then remove it with angula or two piece. With this vest, you can expose your epidural space lately. Lately tearing of dura, you can control without conversion of open surgery. That is my plan today.
Take 3 seconds, please.
Good afternoon, sir. Sir, would like to know that during endoscopy when water is flowing, how would we detect the subtle dural tear? Because would it be difficult to know whether it's water or getting mixed with CSF?
Actually, the big advantage of endoscope is you can see it very clearly with the magnification field. So we can find the tearing or root rat, and sometimes arachnoid membrane. So we can recognize the tearing of dura. If there is severe dura tear, we know very well some eruption of root rat, also finding of dura tear. But you can see very easily the finding of dura tear with my endoscope.
Thank you, sir. Thank you.
Dr. Park, is there chances of increased instability because she's a very elderly female, 80 plus years?
I believe one of the advantages of endoscope surgery is we can preserve passage joint more effectively. He is 81 and have a severe degeneration, and his segment is already stabilized. So with the preservation of passage joint, we can decompress effectively.
Thank you.
Welcome, Dr. Park, Delhi. I want to know whether you will remove the disc here if it is contained. Whether you will remove the disc in addition to the flavor. Yeah.
In this case.
I cannot find on the MRI. I cannot find the existence of a disc, but I can make sure of the decompression, ligament flavum, and I will track the root and find is there any compression by the disc. I will make sure of decompression.
Thank you.
Yes, please. Yes. This is a case, second case in OT-3. This is Mr. Y who presented, who's a 25-year-old male who has presented with complaints of low backache since 3 months, relating to bilateral lower limbs, left lower limb more than the right limb. And he has also complaints of numbness and tingling and weakness of the bilateral lower limbs since 3 months, and complaints of stiffness of bilateral lower limbs since 3 months. The patient doesn't have any bowel or bladder involvement, but he has a history of trauma due to ground level fall 3 months ago. The patient doesn't have any known comorbidities. On examination, on motor examination, the bulk is normal in upper limb and lower limb. The tone is increased in bilateral lower limbs. He has grade 2 spasticity in the right lower limb and grade 3 spasticity in the left lower limb. Power is 5/5 in the bilateral upper limbs and 4/5 in bilateral lower limbs. And the deep tendon reflexes are 3+ in bilateral ankle joint, knee jerk and ankle jerk are 3+, and bilateral plantars are extensor. On MRI imaging, there's D9, D10 PIVD with ligamentum flavum hypertrophy with cord signal changes. So I'd like.
Yeah, this patient is thoracic compression T910. Okay, show me sagittal MRI. Okay, this is very good. So yesterday I watched my patient. His left side is spastic, and it increased the DTR. So and on CT, on the ventral compression, slightly ventral compression, and the posterior compression due to ossification of ligament flavum. Today my flare is only posterior decompression. with a bipolar endoscope surgery. I believe compared to microscope surgery, we are doing the endoscope surgery in the water base. During the drills, everybody have some experience. During drills, there is a lot of heat generation during bone drills. But I'm doing drills in the water, so there is no heat generation during drills. The heat which is generated during drill is transmitted to core, so it makes harmful effect, post-operative weakness of legs. But we can prevent the heat injury from the drill because I'm doing in the water mediate with the endoscope.
Any questions? So what?
CT scan.
Sorry, sir. CT is no, it isn't uploaded on the video.
So it's ossified, sir. It's a calcified disc. CT is not there, but it's calcified.
Professor Park,
Yes.
what is your take on ossified dura? How do you deal with it?
Ossified dura.
Yes.
Actually, several signs of ossified dura, but I think on MRI and CT there is no severe lesions, and I cannot make sure the CT. I cannot see the CT, so I don't know the existence of ossification of dura. But I believe it does not matter because I have my surgery is having drilling stage and the separation of ligament flavum stage, and I can remove the ossified ligament. Even there is a severe lesion, I believe I can treat it.
So you had mentioned that specifically for this case, you would need a diamond burr. But that is a specific requirement.
Diamond bone. Usually my surgery is drill out the laminar bone, especially inner cortical bone and the medullary bone with the remaining outer cortical bone. So left side laminotomy, nearly hemilaminotomy, and the contralateral sublaminosoplasty, removing inner cortical bone and the inner medullary bone, and the remaining ligament flavum, and separate the ligament flavum from the bone, and take it out the calcified ligament flavum.
Thank you.
The last case.
Professor Park, any comments on localization? How are you planning to localize the level? Level, yes.
Yeah, we have double needle techniques. Usually I have L1 needle on one, and the other needle, another needle 9-10 before operation, and double needles, and make the levels, correct levels, and try to skin incisions.
Are you planning to use methylene blue for?
Yeah, if you have match blue, it's very helpful. Yeah, before skin incision, I would like to inject methylene blue on near the lateral recess, and during operation with endoscope, I can make sure the methylene blue. We can believe there is a correct levels without additional X-ray check.
Anytime do you do pre-operative localization? Not intraop, in pre-operative.
Pre-operative on this, when you make a CM, under the CM, L1 needles and T10 needles, under T10 needles, inject the methylene blue there. Okay.
Hello, sir. Good morning. Good morning, sir. Sir, just want to know, as this is OLF, it will be more like stony hard than the other things. So do you think that a normal drill or diamond drill will work, or you will use the other sharp drill for this, or any experience of using a bone CUSA? Because it will be very stony hard as compared to the OLF. OLF would be very hard.
You mean
The OLF, ossified
OLF? I don't know. I don't know what.
ossified ligaments of flavor. It will be very hard.
From what? No. Ossified ligament flower drilling is make a thinning. If the ossified ligament problem, I like to make island. It means second ossified ligament problem make island. It means I make a zone, compression zone, and normal zone and safe zone. So at the compression zone, I cannot insert any kind of instrument, such as a punch or other things. A compression zone with a drill, I make it island and lift up. Yeah.
Any use of bone CUSA in this type of cases, sir? Bone CUSA. Any
Just
bone
repeat the
CUSA
question.
does it be helpful for this type of cases?
Bone CUSA.
Bone CUSA. Actually, I don't have, and I don't need for that. For OLF removal. Actually, my clinical experience for bipolar OLF removal was 120 case in my our hospital. So I don't need for bone CUSA.
Thank you.
Thank you, Dr. Park. So rest of the case discussion will be done after the inauguration ceremony. Dr. Pauna.
So good morning everyone. We would now proceed with the inauguration ceremony. I would first the dignitaries over the dais. So may I now call upon the stage Professor M. Srinivas sir. Professor Shailesh Gaikwad sir. Professor Shashank S. Kale sir. Professor Girijarat sir. Professor Sharat Chandra sir. Professor Ashish Suri sir. Professor Deepak Agarwal sir. I would now like to invite the dignitaries for the lamp lighting and Saraswati Vandana.
Thank you.
Thank you, sir. I would now like to invite Professor Deepak Agarwal, sir, organizing secretary of the workshop, for the welcome address.
Good morning to all of you and dignitaries on the dais, Professor Srinivas, Director AIIMS, Professor Gaikwad, Chief Neurosciences Center, Professor Kale, Head of Department of our Neurosurgery Department, Professor Sharath, Unit Head, and our esteemed foreign dignitaries, including Professor Kolosov and Professor Park, who are here with us to teach us. I thank each one of you for coming over for this event. I think Dr. Datta and Dr. Meena have worked very hard along with Dr. Ramesh, Dr. Pankaj, to make this event a very educative one. Spine surgery is one of the happening specialities today, and we can see from the interest all across this nation that people are very interested specifically for minimally invasive and endoscopic spine surgery. And we plan to showcase the cutting edge of this specialty in the next few days. So I again welcome you. Thank you so much.
Thank you, sir. I would now call upon Professor Chandra, sir, co-chairman of the workshop, to address the gathering.
Honorable dignitaries on the dais, Director, sir, esteemed faculty both from national and international, and delegates. This has been our 10th year of this workshop, which started in a very small way in the seminar room, and then we shifted to the conference room, and today we are proud to say that we have more than 200 registrations. And this is, I think, the one of its only kind of spine workshop across the country, which shows the entire spectrum of spine surgeries. You go to some orthopedic oriented conference, you will see a lot of fixations, a lot of screws. There's no neurosurgical perspective. And if you go to any neurosurgical, there's less of scoliosis shown there. But over here, we are covering the entire spectrum of spine. We are going to operate 15 to 20 cases just in a matter of 3 days. And it's going to be definitely an academic feast. From that perspective, I congratulate Professor Deepak Agarwal, Dr. Rajesh Meena, Dr. Dattaraj for all their untiring efforts, and of course Dr. Pankaj Singh here. All the faculty have worked very hard to make this spine conference a very good success. And thank you once again for coming, and thank you Professor Srinivas once again for coming for the inaugural address.
Thank you, sir. May I now invite Professor Suri, sir, to address the audience.
Director, sir, Dr. Gaikwad, Dr. Kale, Dr. Sharath, Dr. Deepak, all my friends, dignitaries. It's a very proud moment for the department to have been organize this cadaver workshop plus live surgery workshop. Spine surgery, spine admissions constitute nearly 40% of our in-house admissions, both in the main department. We do around about 5,000 cases, surgeries overall in the neurosurgery department, in the main as well as the trauma combined. 40% is always spine as admissions. And it's very important for the resident training program which is to build the skills to learn the spectrum. And I would, though controversial, I'd make, since I've been given this chance to speak, I think two radical statements. Maybe there are a lot of difference of opinion, but I think it's important at this time. I think one, especially for juniors and residents who are, if you're specializing in spine, think of the whole spectrum. Don't be only motivated by titanium addiction or some other addictions possible. Think of the whole spectrum. The congenital is there. There is pediatric spine. There's craniovertebral junction as well. There's degenerative spine, and there is scoliotic spine. So a lot of spectrum is there. So if you are specializing in spine, I think the whole spectrum needs attention. You'll be giving a lot of goodness to the specialty and a lot of goodness in the patient care. Second, more controversial. I personally feel that spine is a cage. It's like the skull and the brain. The relationship of the spine is ultimately, God has given us a spine to take care of the spinal cord and the nerve roots. Otherwise, the spine wouldn't have been just a biomechanic feeling for us to move around. There is a proper segmental distribution. So the main issue is, what is the main aim of spine, the whole of spine surgery? One is to give you the proper balance and the movement and the mobility, and that's fixed. The boning concept is there. Second is protect the nerves, the spinal cord and nerves, so that you restore or improve the neurological function. I personally feel that neurosurgeons should be in command of all spine surgery units. That is another statement. But I thank the organizers, Dr. Deepak Agarwal, Dr. Pankaj, and Dr. Dattaraj. He's been very enthusiastic and Rajesh Meena for a wonderful show. Thank you very much.
Thank you, sir. I would now request Professor Kale, sir, Head of Department Neurosurgery and Chairman of the workshop, to address the gathering.
Professor Srinivas, Director AIIMS, Professor Gaikwad, Head of the Department of Neuroradiology and Chief of Neurosciences Center, Professor Sharat Chandra, Professor Suri, Professor Deepak Agarwal, all my friends from all over the world who are here. Is Professor Visochi here? He's just come, okay. And Professor Kolosov, Professor Park, Dr. Raja Kumar, my friend from Pune. All of you are here. Welcome you all. Dr. Srinivas was asking me that, why do you need to do this inauguration? You know, you have already started, you keep on discussing. Apna kaam karo, if that's what he said. But you know, there is something called tradition. And there is a very fine statement which says that well begun is half done. So this is the beginning. So you have to begin well. You have to begin well with all your seniors around you. And then only it's done well. Well, I'm sure we will do well in this workshop. It offers you cadaver experience, live surgery, case discussions. Tried to cover almost every aspect. That's Dr. Deepak Agarwal and his team. I'm not going to name individual. The whole department has been involved. All the faculty, all the residents, all the staff, they've worked very hard to put all this together. And I welcome you all to enjoy this feast for the next 3 days. The academic feast in the daytime and the other feast in the evening, like yesterday. So welcome you all once again, and let us begin. Thank you.
Thank you, sir. I would now invite our guest of honor, Professor Sailesh Gaikwad, sir, Head of Neuroradiology and Chief CN Center.
Respected Director, sir, Dr. Kale, Dr. Shara, Dr. Ashish, Dr. Deepak Agarwal, and I should specially mention names of Dr. Deepak Agarwal, Dattaraj, Pankaj, and the entire team, the entire department from neurosurgery, who have been working tirelessly over the last few weeks, and I've seen the enthusiasm amongst the youngsters to make this happen and take it to a next level. I'm very proud to say that this is the 12th annual spine workshop. And I like the format, like first there is a cadaveric workshop followed by a live demonstration of the very complex cases. And to make this happen, I think they have gathered very doyens in the spine surgery who are coming from abroad, but also from within India. And I'm sure the scientific program will teach you a lot. So enjoy this gathering, enjoy the academic feast, the socio-cultural evenings in the night. And yes, I won't say that enjoy the weather in Delhi because this is monsoons now, but still I think you are in the comfort of the indoors. So thank you very much.
Thank you, sir. I would now request our chief guest, Professor Srinivas, sir, Director AIIMS New Delhi, to address the gathering.
Thank you. Good morning, everybody. Respected Professor Gaikwad, Professor Kale, all the dignitaries and the faculty from India and abroad, and special welcome to the people, Professor Kalsho and Professor Park, and all the delegates who have been here. I was just discussing with Professor Kale that, when we do newborns and the pediatric cases, whole abdomen is a very big one, and you were saying that you put 2 ports to the spine. Very exciting, I think. I'm sure we must give a big hand to the organizers who have done this. I think this is something which is a very important thing. Bringing the best of the people from all the parts and bringing them here and having an in sequence, the way it is being planned, from the cadaver to the 2-day extra clinical workshops. This will definitely inspire our youngsters. They definitely take up these techniques so that it becomes more minimally invasive, and then we carry forward. There should not be gap in what the entire world knows as the best practice or the new innovations, the surgical innovations, to our own students and the colleagues and the youngsters. That's something which I must commend the entire team, which has brought the best of the people here and taking into the things. And again, welcome you all to the AIIMS New Delhi and to the India, and then look forward that all the people who have come here will definitely carry forward this message and then practice and get connected with the people. You have the best of the people in the neurosurgery and the spine surgery here today in the audience. So get connected with them, continue to do that, and then propagate that, whatever you learn and see today, so that the benefits go on to the patients, so that it becomes more minimally invasive and complex cases are taken care. Otherwise, as people say that, that who should be operating, the best of the people should be operating. I think the best of the people are the neurosurgeons because they know not only the brain but the spine, but also the consequences of everything, Otherwise, we don't end up in giving the functionality to the things which are there. So once again, welcome to All India Institute of Medical Sciences, New Delhi, and then looking forward that the best of the demonstrations and your interactions, the clinical interactions will go a long way for all our patients in the country. Thank you very much.
Thank you, sir. We would now like to felicitate the dignitaries on the dais with a bouquet. Srinivas, sir. Professor Gaikwad, sir. Professor Kale, sir. Professor Chandra, sir. Professor Suri, sir. Professor Deepak Agarwal, sir. Thank you. So now we would like to felicitate our international as well as national invited faculties. So may I now request the dignitaries to felicitate our invited faculties with a plaque. Professor Park from Korea. Professor Massimiliano Visocci from Italy. Professor Kolasov from Russia. Professor Raja Kumar Deshpande from Bangalore. Professor Sushil Patkar from Pune. Professor B.S. Sharma, sir. Thank you, sir. Vote of thanks. I would now like to invite Dr. Dattaraj, sir, co-organizing secretary of the workshop, to present the vote of thanks.
Dear Director, sir, dear senior faculty members, and my dear friends, it's my privilege to give a vote of thanks to this August gathering. On behalf of all my colleagues, I express my hearty thanks to all my honorable guests and senior faculty members for joining this occasion and officially inaugurate this workshop. I express my special thanks to all my international guests, Dr. Park from South Korea, Dr. Massimiliano from Rome, Professor Sergei Kolezov from Russia, for taking time out from their busy schedule and joining us and making this as an academic feast. I'm also very much thankful to all my national faculty, Dr. Deshpande, Dr. Patkar, and our beloved Professor B.S. Sharma, sir, for gracing this occasion and making it very much interactive. I also extend my gratitude to all the delegates without whom this workshop is not possible. And your active participation since yesterday made this workshop phenomenal success. And thank you very much for joining in large numbers and being active all the day. This workshop of this magnitude cannot happen overnight. It requires month and month of the planning, and to make it of this magnitude, you require a good support. So I'm very much thankful to the spine of our department, Professor Kale sir, our senior faculty members, my dear colleagues, and our dynamic organizing secretary, Dr. Deepak Agrawal sir, to make all the efforts so that we make it a very good academic event and make it a successful one. So thank you very much, all my colleagues, to make it happen. Also, I extend my special thanks to all my senior faculty members and colleagues from Department of Neuroanesthesia, Neuroradiology, from Neurophysiology, whose support is paramount for conducting workshop like this, which requires a meticulous planning and teamwork to conduct a workshop of this operative cases. I also extend my special thanks to my support staff, my OT staff, my staff from the organizing team, which worked very hard to make this workshop a successful one. And thanks to all the sponsors for their generous academic sponsorship for making this event possible. With this, I conclude this ceremony, and we can join for the breakfast in the foyer. Yeah. On the first floor.
Breakfast is on first floor.
Can I talk? Can I talk about my surgery?
Yes, please.
Yes. Hello, everyone. It is my great honor to have live surgery in front of you and this wonderful hospital. So today I want to show you how to have radiation free ULVD. ULVD means unilateral laminectomy with a bilateral decompression. So, and how to complete the bipolar endoscopic surgery. Actually, the endoscope is 4K. The resolution of the endoscope is really 4K. And nowadays, we also have experience for 3D endoscope, also possible. And we are trying to, for the interval from decompression with the endoscope, from decompression to the interbody fusion, including decompression, including cervical and thoracic, and interbody fusion, and intradural from regular tumor removal. We can do it with a bipolar endoscopic surgery. The big difference between unipolar and bipolar is bipolar has a two-port. Two-port means two skin incision. So left side skin incision, we can insert the endoscope, and right side skin incision, we can insert the instrument, such as trees, punches, other things. So there are freedom between endoscope and the instrument. It is a very big advantage compared to unipolar. As you know, unipolar has only one house, one channel. With the same channel, endoscope and instrument have to move with the same channel. It is very inconvenient. But bipolar, there are independency between endoscope and the instrument. So that is why it is so handy and so easy and so safe. So, and the most important thing for this surgery is maintenance of fluid movement. It means if you maintain the movement of fluid is make clean your surgical field with washout of bloody water and bone debris. Other development is a self washout because there is a movement of fluid. So the biggest difference compared to microscope surgery. Microscope surgery is an air-based surgery, but this is a automated surgery. So the pressure on the surgical field is transmitted to the intraventricular brain. So if you press over surgical field, the press on your surgical field is too high, it can be transmitted. It can be transmitted intracranial. So you have to be careful. The problem of intracranial problem. The best way to prevent the increasing the press is maintaining the outflow. If you have any question to me, please let me know. Hello?
Yes, Dr. Park.
Can you hear me?
Yes, we can hear you.
Yeah, and can you understand my talk?
Yes, somewhat. The question is, what is the pressure you will be using? Yesterday, I think you showed us.
Yes.
So,
because we are neurosurgeon, so we know very well which is a normal intraventricular pressure, intracranial pressure. Actually, normal intracranial pressure is 5 to 15 millimeter Hg. So your press for the operating period, the press for your operation period also not exceed than 15 millimeter Hg. So how the maintaining good press is maintaining good outflow. So If your outflow is good, your surgical field must be clean. If your outflow is not good, the whole body, you cannot see your anatomy. So you can see your anatomy clearly, it means your outflow is good. And don't worry about intracranial ICP problems.
Can we have the imaging in the PIP?
Okay. Yes. Okay. Yeah, you can see the cytal left side, the cytal MRI. Left MRI, you can see the severe compression of cycle stack on L45 levels. Okay. Here the L45 levels. And also you can see here, actual view, very severe.
Yes.
Severe spinal canal stenosis, serious grade D, okay? And okay, very good. Maybe it's impossible. Or is it okay? Okay. Let me explain this one. Yeah, we know very here is L45 interlaminar space.
Yes.
We know very here is the iliac crest. Okay, you can palpate the interspinous area. You have to palpate the midline and the interspinous area. I mean, here is the interspinous 4-5 interspinous area. 3-4. No, sorry. Even 4-5 interspinous area, 3-4 interspinous area. And I can draw here. So here. So I'm marking here, and you have to know. Here is the most important. Here is the most important things. Please focus on me. Everyone be quiet. Sorry. I'm explaining about
yes, we're listening.
The most important thing is the location for the working port, skin incision. You have to learn. And the best skin incision is lateral recess. Because the lateral recess is the most deepest area and the most dangerous area. So your skin incision always include lateral recess. So there are two types of skin incision. One is vertical, one is vertical, and the other is transverse. I like to have transverse skin incision on the lateral recess. Lateral recess means upper one third of pedicle on lateral view. Your needle, T1 needle is located upper one third of pedicle, distal pedicle, low pedicle. And nearly, medial part of here, pedicle, that is the best location for the needle markings. And then you can make a skin incision from the midline to the lateral like this. From the midline to the lateral over the lateral recess, about 1.5 cm. That is the best location for a working port. Working port means the skin incision for the instrument. And the other one is for the skin incision for the endoscope. Usually from here about 2 cm cranial. Because I am a right-hand surgeon, so standing left side is best, very good, more good. Also, so from here is a skin incision for the working port, and cranially 2 cm above, you can make another skin incision for the endoscope. So for the bipolar surgeons, standing left side, if you are right-hand surgeon, you have to try to stand the left side because of the endless of the drillings. So left side standing is much more easier compared to right side standing. So I'm talking about the location for the skin incision. I will summarize it again and I'll show you. Welcome. Okay. Okay, everybody, move, be careful. Be careful, be careful. Don't talk away. I'm going. Okay, hello everyone. I want to explain my survey. Yeah, I am palpating iliac cluster. Iliac cluster. Yeah, you can palpate iliac cluster roughly like this. And I can palpate the interspinous area here. Pen, 줘봐요. pen, marking pen. No, too thick. So okay. No, it's okay. It's okay. It's okay. Yeah, after palpating iliac cluster, and I am just before I palpate the interspinous area, and I can palpate another interspinous area.
Camera view दे दें.
Yeah, here is the midline. Can you see? And you can roughly I can here. So
OT-3 camera view.
Come close. So I believe here is a profile interspinous interlaminar area maybe. So we can from here I can. Okay, come here. Okay, and then we can make a needles. Yeah, here is the interspinous area, just laterally here, okay? And then gentle touch, just like acupuncture. Careful, and touching the like this, and try to palpate the bony prominence like this. And then try to eat. Yeah, like this. Okay. I can feel some bony prominence here, and then we can inject the small. Okay, it's bleeding. Okay. No problem. Okay. Siam also not. Okay. No. I don't like Siam. It is. I need another one. Okay. Another needle, please. Don't worry. No, give me. 피가 니들 너무 큰 모양인데 작은 놈들 없나? Okay, it's okay. No. Okay. Let's check. Siam, please. Okay, Siam. X-ray, please. Okay, move.
सियाम को PIP में कर लेना.
Oh, AP, I need it, yeah.
कैमरा को PIP में रखो. OT-3.
सर OT-3 में सियाम में आउटपुट नहीं है सर, वो डायरेक्ट कैमरे से.
हाँ, तो एक चीज PIP में तो रखो, कैमरा को और सियाम के एक ही चीज आएगी.
ये सर.
Lateral and AP. Lateral and AP, okay. Okay. Check lateral, okay. Only lateral, please.
Hello?
Yeah. We are checking lateral view.
Okay, sir. Okay.
Yeah, with X-ray, we are checking lateral view, and I want to make sure the location of the needles. Oh, no. Check again. Show me my needle correctly. Yeah, I think that's, I wanna. No, sorry, move back. Sorry, 1 second. Move, sorry. Very needle. Show me L5 pedicle. My needle is upper one third of pedicle. Show, yeah. Camera. Please focus on lateral view.
We are seeing, sir.
Can you see? Yeah, it's right. Can you see? Yeah.
Yes.
So on the lateral view, the best be quiet. Sorry, I have to focus. Everybody be quiet. Look at me. On the needle is toward one third of the pedicle, L5 pedicle. Yes. That is the best location for our skin incisions. Everybody be quiet, okay? And move back. Actually, it is enough. It is enough for the skin incisions. Do you understand? So I don't need a X-ray. No more. Okay.
Patient पे focus कर लो. OT-3.
Okay. Please remember, on the lateral view, distal pedicle. Remember, upper one third of distal pedicle. That is the best location. Usually there is a lateral recess. So and after bone touch, we can insert the Michelin balloon here, but there are some bleedings. So I don't like to put this one, and only I try to. Very bloody. I don't know. This I don't know. This patient had a very easily bleeding. I don't know. So I want to recommend to anesthesia systolic press, maintain systolic press 90, sorry. Nearly. Because easily bleeding. I don't know why. Okay. Just before. So take it down, please. Very easily bleeding. I don't know. Take it down.
Dr. Park, what did you just inject?
Yeah, just before I inject the Michelin blue, during my operation, I can find the Michelin blue. It means our array is correct. So from the midline to the laterally, about 1.5 cm, I want to make skin incision for a transverse skin incision. Everybody be careful, everybody be quiet, if possible, be quiet. And from the midline to the laterally, I'm making skin incision. This skin incision must include fascia, because you have to cut the fascia. Fascia prevent the outflow, movement of fluid. So cutting the fascia is very important. And now I have balloon tip. This is a balloon tip. I can palpate. This is a spinal process. I can dissect like this and move to the more deeply. Here is intracranial space. So just like this, touching the spinous process firstly, and just a G line, make a G line like this, and move to the more deeply, and then you can palpate the interlaminar space. I can palpate the interlaminar space here. So with this angle, we can palpate the distal margin of the L4 lamina and interlaminar space
Dr.
here.
Park, can you just orient us cranial and caudal?
Yes, sir. Left side, because I am a right-hand surgeon, so left side is the brain.
Yes.
Right side is leg, and I'm standing only left side. You can try this one. I'm palpating. Yeah, you try. You can palpate the interlaminar space. Okay, low lamina between upper lamina, lower lamina. We call here interlaminar space. Okay. Can you do it? Click. Okay. That is interlaminar space. Do you understand? Interlaminar space. So because this is a live surgery, to make sure the levels, usually I cannot check the CM again, X-ray again, but this is a live surgery. So I want to make sure the levels again. So be careful. X-ray again. Do you understand? Because this is a live surgery, so I will check the level epilateral again. Back. More back. More back. Yeah. Just before I put the handle, next handle into the interlaminar space. I'm making sure the location of the tips. It must be located the midline and the interlaminar space. Check.
Dr. Park,
Yeah.
I have one question. If there's a disc herniation on the right side, still would you stand on the left side of the patient and operate?
Yeah, usually.
Or you prefer to stand on the
Yes,
right side?
I call it contralateral approach.
Okay.
Yes.
What is the size of the incision that you have put now?
1.5 cm for the
Away from the midline.
Shoot again. AP again. Yeah, AP. You can see there is interlaminar profile interlaminar space. AP dojo. So 100% here is your profile interlaminar space. Can you check the AP X-ray?
The incision is put 1.5 centimeters away from the midline.
No, from the middle to the lateral, transverse skin incision. The length of the skin incision is 1.5 cm.
Okay.
I can understand. Okay. Please, AP activities. Why is it so difficult? I cannot understand. Is it radiologist? No? I'm checking. It's only for make sure the levels. Okay.
Can we just rotate through the ORs?
Okay. Please focus it. Okay. It's 4-5. Okay. Move back. I don't need more. Okay. I don't need X-ray more. So. Okay. Yeah. You can go out. X-ray. Okay, okay. Okay. Okay, hello everyone. I want to continue my talk. So everyone be quiet. So please be quiet for me. So this needle, you can see this needle is located interlaminar space. The lamina between L4 and L4 lamina. Okay. So this I call this is a working port. So with the blunt T, we can dissect muscles from the lamina. You have to know there is no attachment between muscles and lamina. There is only muscle and lamina. There is only pen layer, no attachment. So only separation of muscles from the lamina. I am palpating interlaminar space and palpating medial wall facet joint here. Also, I can palpate the distal lamina, L5 lamina, L4 lamina, interlaminar space. The most important thing is this angle. You have to remember this angle. When you start your drillings, you have to start these angles. If you are starting, when you start your like this angle, you have a mislevel, okay? And if you have this angle, it also mislevel. So your drilling should start this angle because here is a spinolaminar junctions. And 드라이거죠. 올라. only touch here. Okay, and we need another skin incision. Another skin incision for the endoscope. So usually cranially 2 cm above. I can palpate above interspinous area here. Here is usually best place for another skin incision for the endoscope. So I'm making another skin incisions. Usually this is for the endoscope, so you need 0.7 cm, 7 millimeter. 7 millimeter is enough for us, So make it, including fascia, like this. And then put it toward the lamina, toward the midline, toward the spinous process, and toward the lamina. You can palpate the lamina bone here, try it. You can palpate the lamina bone, so you have to make a triangulation on the lamina bone. This is a muscles. Why so many talks? Please tell me, talk, okay? So, if you make your triangulation in the muscles, it's very difficult to make a triangulation. So my talk is always try to make a triangulation on the lamina, not muscles. I mean, we call this is a triangulation. This triangulation is always on the lamina bone. Do you see? It is a very important point for our surgery. So you can make triangulation on the lamina bones. So you can feel that, like this, you can feel the metal. Yeah. Can you see? Yeah. Okay. For education. Okay. No. I told you, touch the lamina, not muscle. Okay, these angles. Okay, and you can feel the bone like this. Okay. For education, I want to show you the X-ray, okay? Come in. Yeah, share X-ray again. Be careful, everybody.
Can we shift to OT?
Yeah, this is only for the audience.
OT when you are connected, sir.
41 main screen.
OT1, what is going on? Scoliosis surgery. Who is assisting in OT1?
Can change it this one, like this. Okay. It is all.
Volume बढ़ा दो.
Yeah. Let me explain again. This is a tube for the endoscope. This is a tube for the instrument. So we call here working port. And this is the endoscopy port. And it is a pre-endoscopy stage. And I want to put the endoscope. Conclude.
Dr. Park, I have a question. Before you put the ports inside, do you make a fluoroscopy? Do you take a C-arm shot with both the dissectors, with both the incisions?
Sorry. Yeah, it's weak. So wait a minute. So you have to check the pressure water. This is too weak. So you have 1.5 cm press, okay? So you have to elevate the height more. It is too weak. It's also very important. And you know this is only for the camera. So this fluid is too weak. So make it more elevate. Or you can use a PP curve. It's also weak because this line is too small. Usually we use a bigger line and a longer line. Yeah, it is not good. Because the line is too small, so fluid is too weak. So for the PP curve. Yeah. Checking the pressure is also very important for your surgery, successful surgeries. So, hello? Yes.
I have two questions. One is, what are those plastic sheets that you're using? Any specifications, any particular brand or make that you're using?
Well, I don't understand what you mean.
The ports that you're using.
To put what? Working port. Yeah, this is actually I designed this trocar because when I started my bipolar surgery, this maintaining fluid is so difficult. So usually there are semicircular metallic tube.
Yeah.
But I don't like. Sometimes it is a pull out and very difficult to control. So I find it and design it. So I use it. So I like to use this one. So it is a primary idea.
Is that available commercially for use in India?
Maybe impossible. But in Korea is made, and you can buy it.
Okay. And how deep are those cannula going?
What?
How deep do they go? Do they go to the lamina?
Always the T is on the lamina bone, okay? You always touch the lamina bone. I can feel the lamina bone here, okay?
Okay.
I need more press here. You can do the BP cup pressure. And try to change the fluid line.
Yeah. What is the brand of those sheets? What is the company name?
If you don't have a water pressure, you cannot continue the surgery because you have to maintain the outflow. Please take it down, please. Take it down, please.
What is the scope?
Yeah, take it down, please. More, take it down. Okay, stop. It's good, wonderful. Thank you so much. And you have to find the T-level instrument here, and I'm looking for the pressure. Make press, water press, please. Making optimal press is the most important. You can see the here. You have to find the instrument here with the endoscope. Okay.
We have some questions from the audience.
Yes.
The endoscope you have put cranially. Sorry, the camera you have put cranially, right?
Yeah, left side endoscope port.
Endoscope port inferior.
Cranial part. And
camera is cranial and the working channel is
right side. So right side is the working port, okay? Working port. And left side, okay, can you see here? Please focus the maybe endoscope. Yeah.
And the endoscope is 0 degrees, right?
Yes, sir. No, you have to video is here. Commercial, okay. Cutting. Yeah, hello everybody, just before, this is RF, cutting. And you can see, stop. You can see this is a laminar bone. Can you see here? This is a laminar bone.
Can you point the midline?
Midline is 12 o'clock.
12 o'clock.
Yeah, 12 o'clock, midline, stop. I will explain the anatomy of endoscope. 12 o'clock is the midline, and 9 o'clock is the cranial. 3 o'clock is the caudal. So this is L4 lamina. And I'm moving to the interlaminar space, cutting. I'm moving to the interlaminar space. It is here, 11 o'clock. At 11 o'clock, we can find, we need more water press, okay?
Yes.
Yeah, here, you can see here. Everybody, please be quiet, okay? I have to focus my survey. If you want to talk, please go out and have a talk. So stop, coordination. This is here is the interlaminar, yes.
What is the power that you're using for the RF?
RF is usually early stage, and stop. If you are under the bone, we can use the maximum side. Maximum is there on RF. Let me explain about the RF. RF is two types of mode. One is ablation mode. The other is coagulation mode. So if you are under the bone and away from the nerve, you can use ablation mode with a high maximum power. So this is the interlaminar space, as you can see here. This is the interlaminar space, and this is the laminar bone. Okay. So we are. So sorry. Give me. Yeah. Give me. So this is the bleeding from the basis. If you want to bleeding control from basis, you can control. You can use the coagulation mode. This is a coagulation mode, like this. You can elevate the power for the maximum power, coagulation. Maximum power, I need it. Maximum increase, coagulation.
What is the power shown on the machine? And which machine are you using right now? for the RF? Because different machines have different power settings. Can you please
Yes,
guide us
yes,
through
sir.
that?
Yeah, every company has they have their own RF machines. So usually their power number 7 to 1, 7 to 1. So if you are away from the node, you can use a strong power. Okay, if you are close to the URL, you have to decrease the, and you have to use a minimum power. So this is if you are to remove this soft tissue, you can use an ablation mode. Sure. I want to show you how to use it. I want to remove this one. You can use it like this. Clean out the soft tissue like this. Okay. This is this lamina over L4. L4. This is margin of L4 lamina, and here is the interlaminar space. And if you want to control the bleeding here, yeah, this is a coagulation node. You can see the low ligament here. This is the low ligament. I told you here is the 12 o'clock. Here is the 12 o'clock. And here is the spinal junctions. Here is the spinal junctions. I told you. This is a spinal junction and starting point for our drilling. You get this angle. If your angle is just same angle. If your angle is just like this, you will have this level. Do you understand? That's why palpating interlaminar space is so important. So I will start my drill here. Because here is a spinal junction. Do you understand? So just before I explore the interlaminar space, and now I will start my drillings. If you have any question, please let me know. Yeah, you can see here, this one, this is the drill. This is the drill. Let's go. Okay, you can see here, I will show you drill. Can you see here? This is the drill ball. This is the cutting, shape drill. This is actually astroscopic drill. So I will start my drillings. Here is the spinolaminar junction. You can start the drill like this, okay? Like this. You have to run. You have to move superficial bone first. Here is the spinolaminar junction. 11 o'clock. You get 11 o'clock. You can like this. Like this. This is the outer cortical laminar bone. This is the outer cortical laminar bone. You can drill superficial bone first. You can drill superficial bone first like this. Because you are endoscope. Usually you are endoscoping here. So the right from your endoscope, you have to reach here. So you cannot see here, but when you drill out here, the right from here reach here. So that's why outside view, outer cortical bone test is more so important. I need another drill. This is orange color drill is more better for me. Yeah, I am drilling. This is L4 lamina. Can you see? And you can continue your base like this. This is the outer cortical bone, so please drill outer cortical bone first, like this. And then outer cortical bone drill first, and then please move to the inner area, okay? And you can see some Michigan blue here. It means that here is the correct levels. And try to explore the ligand flower. This is a ligand flower. This is the ligand flower. And explore the ligand flower with your job. You can see the Michigan blue here. That's why our level is correct. And try to, this is IAP of L4 lamina. You can go more cranially like this. And continue your drilling, superficial bone first. Superficial bone first, and move to the deeper area like this. Like this. And try to explore the ligament problem. This is the yellow ligament. And here is the left side L4 lamina. You can drill here like this. Please drill superficial bone first. Please drill superficial bone first. And then move to the deep area like this. Move to the deep area like this. Like this. And try to explore the ligament problem. Now you have some important situation. You have to find the midline. So you have to know the anatomy, surgical anatomy of the ligament problem. The shapes of ligament problem is just like a butterfly. That's why I like to have a butterfly techniques. So have a butterfly. When you meet the post-epidural pad here is a midline. You have to remember, this is a very important surgical anatomy. When you meet the post-epidural pad, here is a midline correction. So you can control the epidural bleeding like this and stop. And you can meet bone cutting when I call cutting, okay? There is no you don't have people cutting. You don't have a line for a line. You don't have a full line. Stop cutting. Don't have. Stop. Cutting. So with the ablation mode, we can control bleeding from the bone bleeding. Please turn off to the right. Off to the right. Over right. Turn over right. Off to the right. Okay. Okay. So you can see here is the epidural pad. Okay. So here is the midline. When you meet post epidural pad, here is the midline. From midline, you can go laterally. Left side lateral and right side lateral. So usually the diameter of spinal canal is 16 to 20. It means we can from here we can go laterally 8 mm. Okay. Usually one diameter is 4 mm. So one diameter, two diameter, we can go laterally. Conversion. So we can go more laterally. Roughly 1 millimeter, 2 millimeter. Okay. So cutting. After clean up, your soft tissue like this. Now this is the outer layer organ problem. After you clean up the outer organ problem, you can expose this cell lamina. This is the L5 lamina. Can you see here? This is the L5 lamina. Cutting. Continue cutting. And this is the inferior pole of IAP. Inferior pole of L4 IAP here. So stop. I told you from midline we can go laterally about 8 mm position. It depends on patient's size. Okay. So mostly important thing is you have to expose SAP. Stop. This is the IAP. When you remove IAP, you can expose SAP. Cutting.
Dr. Park, what is the extent of bone removal laterally? How much of the IAP would you like to drill?
Yes, I already talked up. I told you, this is the midline, okay? From the midline, we can go laterally about 8 mm. One delivery is about 4 mm. Do you understand? So, roughly you can, this is one delivery, okay? And the other delivery, you can go laterally. So, the most important thing is the exposure position. Until you expose
superiority.
SAP. Do you understand? So, I want to show you. This is the IAP, okay?
Yes.
So, with this, you can go laterally until you expose SAP. You understand? Please, everybody, please be quiet. I have to focus here. You can do it like this. You can go like this, go and move to the lateral like this. You can go more laterally. And you have to go until you can explode SAP. You know very well, this is a midline. Here is a midline, and I'm separating the attachment ligament problem. You will do like this. Like this.
What is the size of the drill bit that you're using?
Well, 4 mm. 4 mm. Yeah. Usually 4 mm. I like to use it.
And is it necessary to use a guarded drill, or can the drilling, since the ligamentum flavum is there as a protection, can the drilling be done without the guard?
Cutting. Yes, this drill has a hood, so you can protect the nerve or ligament problem. Fluid. I cannot understand. Yeah, I need for a 1 hour surgery, we need a 5,000 cc of fluid. So we need keep two continuously. And wide line you have, wide connection.
Meanwhile, can we shift to OT-4 and can come back soon?
Yes, sir. OT-4 you are connected, sir.
To drill laterally until you explode medial SAP. 알았죠? Coagulation. We are near the lower coagulation. Pituitary 주시고 pituitary. 됐어. So it is very most important thing is how much you have to go laterally. How much you have to go to laterally. The answer is until you expose medial wall of SAP. So this is a lamina. So we are near the Okay, I'm trying to explore the middle wall of SAP here, like this, and I'm separating the proximal attachment area problem. You can see here, this is the proximal attachment area problem I'm doing here, okay? And, okay, just before I nearly complete, 입시 나타나는 켜주려고 알았어. So coagulation. The bleeding from the bone, vessel, we can control the coagulation. Stop. Yeah, the bleeding from the bone, cutting mode, cutting. Okay, cutting, no more, cutting. Okay, so you can see coagulation. You can see here is this lamina. So just before I complete the left side drills, correct. And here is correct. Here is a contralateral sublamina. You can see here. We have to drill here. Here is a contralateral. We mean the right side sublamina area here. Here is the right side sublamina area here. Okay, and you have to drill out. You have to drill contralateral sublamina. You can see here, this is the outlayer ligament problem. You have to know there is a two layer. This is the capsular ligament, the outlayer ligament problem. So if you have to remove the outlayer ligament problem. Cutting. To explore the contralateral. Okay. Yes, cutting. Yeah, and stop. Yeah, I will start the contralateral sublamina drills. You can see here.
Dr. Park, they try to identify midline cleft in the ligamentum.
Vidal, just very good question, thank you. Yeah, can you show it here? This is the midline, okay?
Okay.
Yeah, when you need to epidural, post-epidural path, there is a midline. It is very important. I call here head of butterfly, okay? Head of butterfly and wing of butterfly. So,
yeah, there is an anatomical cleft over there.
Yeah, there also head, is a pad, and there is some cleft here. You can find some cleft, midline cleft here. Can you see it? This is a midline cleft. Well, finding face is much more important. And I'm doing further, yeah. I need more water press, please. Yeah. And, yeah, I'm waiting for it. Well, why is this?
Do you put any antibiotic in the irrigation fluid or it is just lines?
Actually, no need for that because for the 1 hour we have a 5,000 cc irrigation. Open. Camera please. Open here. Okay, this is optimal pressure. You need a water pressure, okay? Your pressure is just like this. You cannot perform your operation. Please make your pressure like this. This is optimal press. So our vision becomes much more clear. Can you see here? Yeah, become very clear because the fluid movement is become good. Do you understand? That's why maintaining the outflow is so much important. You can see our vision is much more improved because of water press. Do you understand? So now I'm drilling contralateral sublamina. This is the right side. This is the right side lamina, sublamina area. So I am drilling inner cortical bone first. And you can drill inner cortical bone and the medial bone. I am drilling like this. Can you see this one? Yeah, you can drill like this. Yes, I'm drilling sublamina here. Okay? We have to know this is a problem. This is one to really protect your nerve damage for this. I mean, this is a problem.
will protect the negative energy from the tree. So we have to only remove the ligand fragment become only terminal data, okay? So, I mean, preserve your ligand fragment until you complete your bleedings. So, and bleedings, contralateral several area here like this, okay? And you have to know until you need the contralateral several area, contralateral facet, okay? This is the IOP, because 100% IOP, because this is the one body of the upper lamina, do you understand? So you can find here, you can go more lateral, you can see the SAP. So this is 100% IOP, 100% IOP. So with the beliefs, we have to try to explore contralateral SAP. So, yeah, I believe until explore the contralateral SAP, you can go like this. And your real problem will protect the nervous energy from the trees. So that's why your trees are so safe, so much safe. You can do like this, like this. And you are deeply like this. Like this. And breathing, if you are breathing, you can see here. And you can do like this. My secret for breathing, when you breathe the contralateral, the direction of the rotation is counterclockwise. I mean, here is the contralateral sublamina area. Like breathe the counterclockwise rotation. And if I have breathe here, ipsilateral, but the rotation is a clockwise rotation. Here is the clockwise rotation this, okay? And here is the counterclockwise rotation. This, like this. So, I strongly recommend you, please make a stage for your surgery. When I call, please. Coalition. Please reduce the power of coagulation. Number 3, reduce 3, coagulation. Continuous coagulation. Make 3, coagulation, okay. Cutting. 3. Cutting, okay. Yeah, let me explain. Fluid. What's the fluid? What fluid? When you are speaking become deaf, you have to check the press here always. The press is good. Okay, and we are here. I don't know why our crew is not good. Okay, so accurate. And we can remove this one. We don't need it because outflow is well made. Okay, so you can remove the talker. Can you see this here? This is 100% IOP. When you dig out here, you can find the SAP. Here is the contralateral facet joint. This is the IOP, and here is the interfacetary plane. So, and this is outlayer ligand problem. So you have to remove this outlayer ligand problem. Okay? When you remove this outlayer ligand problem, you can find the SAP. Let me explain how to find the SAP. You have to find your SAP from the distal lamina. Here is the coagulation. Here is the proximal margin of the distal lamina. Okay, cutting. Yeah, coagulation.
Can we go to OT1 quickly?
Cutting. Okay.
But when you are connected, sir.
Dr. Kalasov? Yeah. Cutting. Can we move on to OT TV junction for a while? Yeah.
Yes, sir.
pituitary. So,
Dr. Park, we are back with you. Could you just explain what you do?
yeah. Yeah, now I'm removing left side renal butterfly. This is left side renal butterfly, just before. Yeah, this is left side renal butterfly. And, yeah, I'm just before I remove it, this here. And we remain, this is the right side, okay? Right side renal butterfly here. Can you see here? So we can separate it from the bone. This way, you can see. Okay. Kill it. Yeah. Coagulation. We can control epidural bleeding, coagulation more like this. And we are going to here, stop. When I call, coagulation. Yeah, this is a contralateral renal problem here. Curate. You have to move here. You can see here, okay? You can see dissection of renal problem. Dissection of renal problem from the dura like this. Here is the medial aorta pedicle. You can see here. This is the traverse root. Can you see traverse root here?
Yes, very nice.
Yeah, and we can two minute punch, please. We can palpate the medial aorta pedicle here, punching. And we can put our punch like this. We can put our punch like this, and remove it like this.
So, Dr. Park, these are standard punches or they are specialized?
Yeah, these are normal punch, which is used in microscope surgery, okay?
Okay.
Pituitary. Yeah, the strong point, the advantage of this surgery is that you can use same instrument which is used in microscope surgery, okay? So you can use like this.
That is a major advantage.
Please. Pituitary, please. Coagulation here, coagulation. Over the pituitary. Coagulation. Okay, over the pituitary, please. With the punch. I mean, pituitary process. Okay. Now I will show you surgical anatomy again. Here is the left side, okay? Left side, and here is medial aorta pedicle. If you not have medial aorta pedicle, you can remove it. Here, clean, please clean. Okay, here, you can remove it here.
So then we should be able to see the traversing route.
Yeah. If not, I am exposing. If not, traversing route. Okay. Here, we are yield. Okay. You can palpate here. Here is the medial aorta pedicle, and you can see here. Okay, double. Action route. If we want action route, we have to go more here. If you want to ipsilateral action route, you have to design your surgery differently. You can see here, this is the traversing route. Can you see here?
Yes.
This is the traversing route here. And you can check the no disc. There's no disc here, okay?
Right.
Yeah, here this is the traction root, and here the medial aorta pedicle here. So this is the lateral marginal dura, okay? And here you can see here the contralateral traction root here. Can you see this one?
Yes.
Here?
Yes.
And here the contralateral lateral recess, okay? And if you want to make sure exit root, you have to go here. You have to drill a lot. You can explore the exit root. So if you have a primary control, RF, please. So just before we complete coagulation, you can shrinkage the inner flywheel with the coagulation over like this. Okay? Like this. Stop. So this is the lateral aorta dura. Okay? Can you see here? Lateral aorta dura, coagulation root, coagulation. And here is the lateral recess, coagulation here. So every root, both the coagulation root is completely decompressed, okay? Coagulation. Here, this is where decompressed, you can see here, sir.
Yes, very nicely seen.
Coagulation. Yeah, fully decompressed. And here is the left side coagulation. Left side coagulation root, here, coagulation. Okay, so and here is the central area.
So surgery is over, Dr. Park?
Yeah, I'm completed my surgery. Here is the contralateral medial aorta pedicle, okay? And here is the ipsilateral medial aorta pedicle. I will decompress from medial aorta pedicle to the medial aorta pedicle. So there is a fully decompressed spinal canal. So we can complete this surgery. So I will piece my surgery here, okay? And here. Annuloplasty we can do. I will show you how can we have an annuloplasty. So actually now I'm making small. So
Decompressions. We do the decompression from?
If you want annuloplasty,
one question is of decompression, we do it from pedicle to pedicle. So are you going to do some work on the exiting route or only the traversing route you need to decompress?
This question, the two-root decompression? Yeah, I will explain. This is the contralateral SAP, okay? This is here is the T-low SAP. Over the T-low SAP here, you can find the exiting route. If you want to decompress the exiting route, you have to drill more lateral here. This part of the bone, you have to drill out. And you have to explore the contralateral T-low SAP. And then you can find the exiting route here, okay? So, if you want to decompress the exiting route, you have to drill more cranially, and try to explore the exiting route.
Are you going to exercise the tip of the SAP here?
Usually we don't need to explore the T-low SAP because traversing route is compressed. So our surgery is which route is compressed. The goal of our surgery is decompressing the root, affecting root. This patient, both L5 root is affecting root, so you have to decompress only both L5 root here, okay? We don't yes, sir.
One more question, please. As far as I understood, there was also a bulging disc.
Bulging disc, yeah.
Yeah. What do you do with bulging?
Thank you for good question. Just like this, coagulation. I'm doing. So now you flat like this.
Yeah.
Well, you can see the shrinkage of the stop. You can see the shrinkage of the sometimes shrinkage of annulus. You can see coagulation. So now I like to have you have to call you have to follow my call, okay? So we are here. This is annulus. You can see here coagulation. So annuloplasty like this coagulation. coagulation, doing tightening coagulation, thermal modulation of the area, stop. Thermal modulation of the areas is very helpful for the, you can see coagulation, you can see the shrinkage of areas like this. Can you see here? Stop. Again, shoot.
So you just coagulate and shrink
Yeah, coagulation,
but not remove it.
like this, yes, coagulation. Maybe we don't rest for it. So just before I perform the other things, coagulation, and the next stage is prevention of hematoma collection, okay? So when you start the input over here, like this, there is no bleedings. Can you see here? Then this is this one. So usually I apply the fresh over the dura, and put it there. There is my surgery. So I want to complete my surgery. So let me summarize my surgery, okay? So you have to stay on the left side, okay? And starting you have to leave spinal laminar junctions, and explore the renal problem, and find the head of butterfly, midline, okay? And laminar region, both sides of laminar release, and explore the renal problem, and find the medial order perica, medial order SAP. We have to separate the medial order SAP, renal problem, open it like this. And then you can take it out, 2 pieces or 1 piece of the renal problem. And then you can complete this survey. So,
one more question, please.
Yes, yes.
Just in case of CSF fistula, leakage.
Yes.
You cannot repair it by switching like microscope approach, just to put a patch with glue, right?
Yes. Yeah. Thank you for wonderful questions. Hello. To that here, okay? We have to check the arachnoid membrane because here is the water-based surgery. Even though there are dural tear, your arachnoid membrane is intact. At that time, we don't worry about the leakage of the CSF, only pathocele patching the something. Okay? If there is some inside the dural tear, also you can control some patchy or other things. You don't need to convert your surgery to the close. You can apply another things. So my told you, if you remove the renal problem lately, your atrial space also exposed lately. Lately telling you can control it. But when you expose only exposure to the PCI removal renal problem, only telling you to make a problem, only telling you to make a problem. So if you have only telling you to you have to convert your surgery to the microscopic surgery. That is my talk.
Hello, back with you, Dr. Saradoti.
Yes.
Thank you,
Dr. Parth. Thank you.
Dr. Shrestha, sir, you are complete, sir.
Good morning.
could be X-ray, MRI films. MRI film पे focus करो. MRI film पे focus करें. OT-3. राजेश, डॉक्टर राजेश. हाँ. इसमें लाइट पीछे का वो कुछ ऑन होगा. तो कुछ नहीं दिख रहा. नहीं दिखेगा सर वो. सर उसके पीछे वो है नहीं. दैट्स अ सेपरेट थिंग. Yes, sir.
Was done by open surgery, one would have offered a much longer decompression. Was just a focus decompression sufficient? That is why I want to see the MRI. There was no compression above that. So you cannot have. I can understand this in a young person with a focus not. But if there is an elderly patient, you cannot have him coming back to the OT again.
Correct.
He's 84 years old.
No, point is well taken. I think that
For 2 levels, not more than that.
there are limits to endoscopy. नहीं, डॉक्टर राजेश मीना, are you there? डॉक्टर राजेश नहीं जा तो रही है सर.
कोई नहीं भाई.
Can we have the MRI put on a view box? क्या कर रहे हैं? चलो सही जगह तो भी डिसेक्शन स्टार्ट की. ठीक है, विल शिफ्ट टू OT-4. हाँ. डॉक्टर शरद, वी आर देयर विद यू. Yeah, so I'm कैमरा ऑन कर दो. Yeah, simulation. Yes. Okay, okay. Did you find the job? Okay. We will start from from L4 to the right side. Middle. OT3 shift करना. Shift to OT3. Okay. Dr. Rajesh. Sir, not ready. OT3. L4. To the right. We want to see the position of the patient. Okay, okay, sir. Okay. राजेश जी माइक लगा दीजिए डॉक्टर राजेश सर को. Dr. Rajesh, can you just tell us the position of the patient? Is it Wilson frame? Hi Rajesh, can you hear us? Because yesterday Dr. Park was saying that he wants his hands on the sides, not up.
No, I think we'll get it. We will get it. इधर बैठे इधर बैठे. Yeah, good. Let's see. If not, we still have.
You can do more और कर लो ना थोड़ा सा और सर.
हाँ राजेश. We can hear you now. राजेश मीना.
करते हैं अभी. उठाओ पेशेंट उठाओ. ये वाला बॉस्टर भी ठीक होगा.
I think there's something important going on in OT1. Can we go on?
Shift.
Yeah.
Shift to OT1.
Yeah, OT1. Also,
Can you please tell us what you're doing with those Dr. Rajesh से connected है audio, he was not able to listen to us last time. आवाज आ रही है क्या?
ये सर एक मिनट माइक लगा रहे सर.
हेलो. हाँ राजेश.
Good afternoon, sir.
Good afternoon. Can you explain the एक बार MRI दिखा दो.
So,
What is this case?
Cameraman. So this is the second case of our OT, sir. So basically, it is a case of spastic paraparesis. Patient has D10, D11 ligamentum flavum hypertrophy.
Okay.
So there is a calcified ligamentum flavum seen in this CT film, sag cuts and axial cuts of the CT films. This is calcification which is seen here.
Right. And plan is?
Plan is to do UBA and remove that calcified ligamentum flavum.
So biportal again?
Yeah, biportal again.
And this is at level of D?
It is at the level of D10, D11, sir.
D10, D11 is the most dangerous level.
Sir.
So what is the power right now of the patient?
Patient is power 4/5 bilateral lower limbs with spasticity, sir.
Spasticity. ठीक है. And the position you are prone on bolster or Wilson frame or what?
Sir, we have positioned the patient on bolsters, sir, two bolsters, one at the level of the chest and other at the level of the hip.
And is the patient shifted towards the side of the surgeon or is in the midline on the table?
It's on the midline of the table and the arms are hanging towards the head so that it doesn't come in our X-ray view. It doesn't obliterate our X-ray imaging.
Okay.
So we have marked the levels. Now we are just doing painting and draping.
So on the CT there was ossification seen at both D10 and D9 or it's only at one level?
It's only at one level, sir.
That is D10.
D10 and D11 there was a calcified disc also and also the ligamentum flavum hypertrophy at that level.
So your approach will be between D10 11, yeah.
So we are planning for that docking that lamina exposure will be at the D11 level. Then we go cranially and remove that ligamentum flavum.
Then we go. Okay. How long will it be before you start?
Sir, I think within half an hour we should be able to start.
We shift to OT1.
Yes, sir. 41 you are connected, sir.
Yeah, little bit.
Yeah. Yeah, can you take us to where with you, Professor Park?
Yes, yes, everything, prepared.
Yeah, yeah. So, okay. In few minutes, we'll come back to you. Yeah.
2 minutes. I will, let's start here. Take.
Can you go to OT-1? Yeah. Professor Kolege, we are with you. We are watching your beautiful
Are you ready? Yeah. Hello, everyone. Let me explain the location for skin incisions. Because here is a thoracic area. So maintaining good outflow is very important. Under the same guidance, I made some T11 localization, and I want to make skin incisions from midline to the laterally, about 2 cm, because we have to maintain good outflow. So more wide skin incision, I recommend more wide skin incision. Skin incision including fascia, and then I start dissections of muscles and palpating interlaminar space. I believe this is a very good method. Now I can palpate the interlaminar space. So I believe here is a 10 and 11 interlaminar space. And also try to the middle part of the facet here. So you can try it. Yeah, you can click. Yeah, click. No, sorry. Here. Yeah. Okay. So, and separation of the pars spinal muscle from the laminar bone like this. This is all. And we need another skin incisions for the bigger cut. And about 2 cm above. Actually, nearly hemilaminotomy is needed. So whenever above interspinous area, I like to have skin incision. Again, another skin incision. This is for the endoscope. Skin incisions. So, okay. And also put it here toward the laminar bone. palpating laminar bone is very, very important. Now I can touch the laminar bone, messenger, okay. And make a triangulation. We try to make a triangulation on the laminar bone, I believe, I know, interlaminar space is at this angles, and like this, and then foot here, also touching the laminar bone here, and another for dissection, dilation of fascia to make a good outflow. Okay, always toward the midline. Here is the midline. Always your motion hand is like this toward the midline. This is important. If you have like this, you can read your anatomy. So strongly recommend always toward the midline. And I'm keeping the this trochus. So right side of the two-way measure for the walking foot, and the left side is for the end score. So just before I complete the, and I told you this is a fluid. This fluid is good. This is good. I think I told you this is too weak. This is good. And we can. The right of freeze. You can find the laminar bone here. Can you see blue? Here, and I inject the Michelin blue here. So yeah, you can find here. This way. Okay, cutting. This is a laminar. This is laminar. 10 laminar, that stuff. Cutting. Okay. This is a Michelin blue, and I'm looking for stop. Coagulation. Sometimes Michelin blue disturb the anatomy, but very easily would we wash out, stop. Okay. Coagulation. Fluid cascading, coagulation. Okay. I'm looking for the interlaminar space, margin of interlaminar space here. You can see that. Stop. Cutting. Yeah, you can see the distal margin of T10 laminar stuff. You can see here is the interlaminar space. So make focus. Okay, I want to make focus clearly. Okay. We can see the interlaminar space here. Okay, coagulation. Cut. Give me hand. Okay. Coagulation like good. Wait a minute. Okay, sorry. I want to do here. Okay. Okay. And expose distal lamina. This is distal lamina. Now we can start our readings. So sorry. Good, please. Good. Okay. And okay. We are here. This is interlaminar space. I don't know why camera is not camera has some problem, not clear. I don't know why. Move back. Deliver, please. Give me deliver, please. Pedal. Where is pedal? Pedal for drills. Okay. Thank you. Okay. We are here.
Hello? Dr. Suri sir, you are connected, sir. OT2. OT2, you are connected, sir.
Nothing like this. With the preservation of a middle structure, we can drill like this. Also, superficial bone drilling like this. Yeah, here is a one level of over. Here is a one level of over intralaminar space. We can see, hold on. I mean, yeah, this one. This is a one level of over intralaminar space. So yes, we have to go until nearly one level of over intralaminar space. Diamond drips, please. Okay. Yeah, changing. Different pedal? Same pedal. I mean, same pedal. Push it. Are you ready? I can use it.
Dr. Park, can you please orient us once?
Yes, yes.
Create caudal, medial, lateral.
Okay, let me explain hello everyone, let me explain the surgical anatomy. 12 o'clock, 4 o'clock is midline, 9 o'clock is cranial, and 3 o'clock is the leg, and 6 o'clock is the left side. So this is the low ligament, and I'm doing to release. This is that. This is the other one. And this is pulled. Okay, good. Really heavy anatomy we have here. This is the low ligament, this is the low ligament. We have to expose both sides of SAP, superior articular process. So I'm doing this. I think we need to change the endoscope, another one. If you have to try another endoscope. This endoscope has some problem. Okay. Change again. Always closed. Yes, and Tomuria is very important. No, I can do it. Okay. And change it.
Can you take us to if you have a question?
Let me do it.
Okay, sir. Open the fluid. Fluid open. I don't know why you fluid like this. You have to do this first. No. Yeah, we need this first, okay? Try again. I think previous one. Previous one. Change the previous one.
Previous one, previous one. Malaki? Okay. Connector, connector. Connect, connect. It's okay. Okay, autofocus please. Water. No water. Why no water? Why no water? I think here is a different. Okay, here. Here to fix. Oh, it's okay. It's okay. It's okay. More higher, more higher. Okay. And the RF, please. We are here. Be careful for wire, okay? This, you know, this is just like a pencil. You can have a correlation, and make focus. Dr. Roy, stop. Make a focus here. No, more. Okay, it's good. Thank you. And we are here. Okay. We need a different area. Yeah, okay. RF. Okay, it should be okay. Cutting. Okay, it's fast. Watch out. You have to make a real anatomy. You have to make a real anatomy. All the way to the midline, and looking for the previous drilling. At the front, correlation. So, okay, we are here, correlation. Stop. Why underscore is not clear? Correlation. Big problem. I don't know. Correlation. Okay. Focus again. So please focus again. Yellow, make a yellow clear. Yellow round, make a yellow round clear. It's empty now. Okay. Here. Yes. Baby. Always take care without dying, okay? because of full coverage of endoscope. There is this is a superficial laminar bone over T10, and we know that here is a 10 over interlaminar space, and I'm exposing ligament problem, exposing this yellow ligament. So,
Dr. Park, any reason you're using the diamond burr this time and not the protected burr?
yeah,
Not the cutting.
yeah, here is the thoracic area, If you use a cell is more bulky, so can cause a compressor.
Right.
So I like to use this electrically, which is used the microscopic surgery. I'm sorry for progression.
Which company scope and drill system you
Progression. Well, I like to strike a company 0 degree. Usually there are 30 degree and 0 degree. Because I am cutting, I am a neurosurgeon, so I like to have a 0 degree cutting. But this is a ligament, and this is a contralateral laminar area. I cannot understand why everything is okay, but the vision is very bad. I don't know why. Do you make a shuffling of the
Dr. Park, you don't use the pressure pump or you do?
Sorry, what? What is
pressure pump?
I feel very good. I don't need it for emergency systems, but we have a problem on the endoscope. The view of the endoscope is very bad. But I can perform my surgery. So this is a ligament problem, and this is a contralateral lamina. So I am drilling sublamina, contralateral sublamina drilling to exposure ligament problem. So this is a medullary bone. Always our drilling is superficial bone first. What hard irrigation, very hard. One year, always. Very mercifully. RF freezer. Progression. Please prepare 30 degree endoscope. If you have cutting. But yeah, reduce the power to the fiber, make a fiber. Cutting power, make a fiber. Do. Then you do hand this first, okay? Okay. Okay, so I don't know why the quality of image is so much better, okay? It is really impossible to continue our survey. Anyway, can you see this is a yellow ligament and this is an outer ligament problem. So with the same method, we have to explore the contralateral SAP. Contralateral SAP, I am doing contralateral IOP, contralateral several drilling here. So, yeah, sorry, please conclude this screen conclude. If it's possible, yeah, make it closer. Okay, you don't need for that. Okay, and okay, thank you so much. And yeah, this is ipsilateral IOP here. What they say? Huh? Focus what? Where the focus again? Okay. And now I'm looking for the head of waterfly to identify midline. So for the section, irrigation, please, very hard. I'm looking for epidural path because the epidural path, first epidural path is midline. So finding first epidural path is very important at this step. We know very well there is a lot of heat generation, but here is a water. Heat surgery is performed in the water, so there is no heat injury. We can prevent heat injury from the drill. You can see here, we are near the midline. We are here. We can find some epidural path here. And we're making several more like this. This is a contralateral lamina. Okay, yeah. Focus again. Okay, good. The reading of the contralateral IOP to install the contralateral SAP. Okay. We need a superficial control first. You can see the retraction of soft tissue with the trocar, like plastic, we can retract the soft tissue like this, and then expose the bone. We can continue our drilling like this, and counterclockwise rotation like this, and clockwise rotation. Here we go, here, RF please. Cutting. Okay, stop. Okay. Cutting. Okay, stop. Progression. Okay, progression, cutting, okay, stop. Yeah, focus again, round the three. Okay. We are here. We know very well, here is the first epidural path. So we can, okay, I'm looking for first epidural path. Always superficial one drilling first, like this. And then move to the deep area like this. Like this. And also try to midline epidural pad. You have to find the midline epidural pad. Can you see here? This epidural pad is the midline. So we have a good orientation for it. And I'm going to the cranial area with a superficial drilling first, like this. Superficial drilling first. And then you can go more deep area like this. The basic is okay, and I want to make a ribbon flower island. We only need a drill. Actually, joining is very, very important. Compression area, I call it a danger zone. So in the compression area, we cannot insert any kind of instrument, including pencil or QS. And normal zone, no compression zone, I call that intermediate or normal zone. Normal zone, we can insert 1 minute punch or instrument. So we are here, I'm exposing yellow ligament with a drill like this. Okay, and going to contralateral area like this. Yeah, and try to expose the eye like this. Superficial boundary is the most important here. And here, and move to the inner area, we can go like this. Alert please, alert please. Sure. Okay, conversion. Cutting, please. Cutting, please, stop. Conversion. Okay, thank you. Conversion. Okay. Conversion. Here is the outer contralateral outer ligament flavum. Okay. Cutting again. Stop. Cutting again. Cutting. Okay, stop. Here is one level lower intraluminal area, okay? We are near here, okay, three. And we want to do more, okay? And here like this. We can do here like this. No tissue code is our surgery, so I am doing only 3 and 3. It is freezer, very hot. And we know that here is here. You know the attachment of ion from is a Y cell, not the umbrella cell. So cranial lateral part is here. We have to go more cranial lateral here. Y cell attachment. I want to show you Y cell attachment of ion from. And we are near the orthopedic here. I mean, the problem is when you follow the touchable line, problem, you can meet the low marginal pedicle here. So if you go here, we can reach the contralateral pedicle here. So we have to go here to separate the problem here, like this. Yeah, you can see the touchable line of the problem here, just like I said. Yeah, yeah. Okay, yeah, we are here. Separation of real problem immediately, okay? Without insert any instrument, we can separate real problem like this. And also to out like this. You can make like this. Can you see here? Okay. I need a more small side diameter. Small side. What kind of side do you have? Only one. Do you have another please? If you have a small size head, please prepare different kind of this. Yeah, we can see here, okay? And you know very well careful. Okay. Suction, take care, suction. No suction, no function. Suction. Where is suction? Okay. I will do my operation, okay? Coagulation. Doctor, coagulation. Cutting shortly. Cutting shortly. Cutting. Coagulation. Cutting. No. Fluid. Check the fluid. Coagulation. No fluid in foot. Coagulation. Okay, coagulation. Do you have this? Cutting. Give me this. Right, take care of the suction, okay? Okay. This is your contralateral IOP. When I do this, we can find the contralateral SAP. Always you have to explore. We have to explore the contralateral SAP. In cervical foraminal decompression, you also explore the contralateral superior articular process, medial superior articular process. So I'm trying to explore the. Do you need change it, No, need reverse. It is not working. Do you understand? Hold it. Okay, three please. Okay. This is ipsilateral, this is ipsilateral IOP here. Here we go, sir. Other please. Check the line, please check the line, okay? Progression. When I call you, repeat the word, okay? Progression. Okay, progression. Shortly cutting. Cutting. I want to, you have to remove, this is outer organ problem, okay? And try to expose this lamina. Wait. Progression. Cutting, please. Cutting, please. Pituitary, please. Pituitary. Okay. We are doing here is the outer organ problem. So, partially remove the outer organ problem, which disturb the brilliance. Okay. Here we cure it. Small size, very small size cure. Do it first. Other please. Okay. Coagulation. I need a small head of coagulation. You know very well. This is distal lamina, okay? Distal lamina. And from here, if you follow the distal lamina, you can find the coagulation. You can find the cutting. Okay. The most important thing is following stop coagulation. Curate, please. Coagulation. Here is a proximal margin of distal lamina. If you follow the proximal margin of distal lamina, you can expose medial wall of SAP. Cutting. Stop. Cutting. Stop. Cutting. So, cutting. Stop. Coagulation, please. Coagulation. We can find it here. Here some medial wall of SAP. Pituitary, please. Okay, wait. Coagulation again. Cutting. Okay, let me stop. Coagulation. Here is a contralateral area. I'm trying to expose the contralateral superior articular process. I'm trying to expose. This is distal lamina cutting. Distal lamina and stop. Cure. Cure, please. Okay. We know very well. This is a distal lamina. So we have to expose the attachment line over from yellow ligament to the distal lamina. Here. And I will follow. This is some big, quite big. Punch, 2 minute punch. 2 minute punch. This William Flowering deserve the vision, so submitted more figure. So I will partially remove this one to watch contractor side. So you can see here, remove partial remove of outer William Flowering like this, and then you can explore the attachment line of William Flowering. Here and here, we are here. Give me accurate. My talk is accurate. Please expose the, okay. Here, we are here. I want a smaller one, too big. You can see here, this is a contralateral SAP. So now you have to find the contralateral pedicle. Down there, please. Other plus. Formation. Cutting. Okay, spool. Cutting. Please. I know. Here, maybe here is a contralateral pedicle. So, this is a lamina, and you have to explore the medial wall of the contralateral pedicle. The reed is not working. So we need a sharp needle means chill please, out please. Moving, coordination. Please check the line, please, cutting. Okay. Cutting. Coordination. If you have three prepared, let me know. Please, thank you. Where's the line? Oh, easy, much more better. Where? Okay, I think, wait a minute. Okay. Where to be there? Forward the weather is the password. Left side with the weather. Not working. Wait a minute. Yeah. Section, please, section, no section. No section?
दो सेक्शन है ना दूसरा कहाँ है दूसरा खाली तो किया था उसने
What can I do?
सेक्शन चालू करेगा तब तो
Yeah, I'm looking for the medial pedicle, inferior pedicle. You can find, Now looking.
No.
I cannot believe it. Okay, agree. Back. Looking for the pelican, okay? Oh, why? Oh, what? Yeah, I don't know why. It's a very simple problem. Usually here the pelican, and after binding pelican, we can become brave, okay? So binding pelican, this is a contralateral SAP, this is a contralateral SAP, and we are moving to the cranial like this, okay? We can find, this drill very good, drill team very good. Thank you for drills. You saved my life. And if we make, if we make, where is section? You can see here, okay. I'm looking for the pelican, okay. This is a cancerous bone. Be careful. Medial oral pelican, checking the punch, please. Oh, okay. Punch, submit punch, please. Okay. So I'm looking for the pelican. Finding pelican is the most important thing here. So we can find the pelican. Okay. Yeah, give me. Because, okay, no. I have to focus on it, okay? Don't talk. Yeah, this is, if you find the medial oral pelican, outside the pelican, medial pelican, there is no nerve. Do you understand? So finding medial oral pelican, and then here outside is a safe zone, so you can become braver. You are really become braver. Do you understand? So finding, I'm looking for this is a cancerous bone. Usually this cancer bone is a pelical bone. Care please. Alright, please. Be careful. Progression. Okay. 1, 3. This is, please check the line. This is the SAP, this is the facet joint, and I'm going to cranial part like this, okay. control the monitor. If possible, please control the monitor. If possible, please control the monitor. It is impossible. Reverse is impossible. Only one direction rotation. Impossible. Okay. Yes, sir. Okay. This is the inferior distal lamina, okay? We can explore. Okay. Possible? You can make bone just like films. Irrigation please. Do you have a different river, more strong, more bigger and more strong? Cutting board, just like a cutting board, do you have? Yeah, same drill, with the same drill. Yeah, irrigation please. Yeah, this is the distal lamina, okay? I want to explore the epidermal space. When you drill here, the color of bone will become pink. Pink means that we are near the epidermal space. So making this white color into the yellow color is very important. Alright, please. Check the line, please. Always coagulation. Continuous coagulation. Cutting. Coagulation. You know very well. Midline. You have to always check the midline, okay? Have a butterfly. Cutting. Okay, stop. Yeah, this is calcified area, but be careful. And look for the midline. You have to always keep in mind, keep the midline, okay? Keep the midline is the most important thing. Right, check the line, please. Oh, I don't know why. Oh, shit. Yeah. Do we have a cutting board? Irrigation, please. RF, please. Okay. Change it. Be careful. Definitely, be careful. Code is opened, okay? So, okay. Coagulation. Be careful. Coagulation. coagulation, coagulation, okay, coagulation. You can see this is a calcified rhythm flower. This is the cord, okay, coagulation, coagulation. Here is the midline, so do please, cutting it. The needle, this is change needle, okay? This is very good to you. So change new one, okay? Check the power. You need full power, not full, it looks not full power. Check it. You have a cutting bar? Change it. Reverse also possible, reverse possible. Which is reverse? Left or right? Okay, when I call reverse, call it, okay? Turn me. Then check the full influence. Give me the flavor. Reverse. It's too sharp. I think we need nearly weapon. Be careful. Right. Please check the foot. Okay, reverse, okay? No input. Is it okay? Okay, make it more higher. I don't know why it is not good. Okay. Okay, check the line. Please. Okay. Oh, no. There's nothing. Cannot see anything. Oh shit. Previously, this one. Save it, please. Save it. No, previous one. Course, new one. Previous new one, please. Alert, please. Coagulation. Okay, stop. Shortly cutting, please. Okay, cutting. If you prefer to let me know, coagulation. Thank you. Okay, this is good. New one is very good, okay? Okay. You have to check where is the midline, okay? Always keep in mind, here is the midline, okay? You can go to the midline here, okay? So, we are safe until here. And the readings, to separate the rhythm from the bone. Reverse, please. Only one, okay, it's okay. Yeah, here is the touching line of rhythm flower. We have to be careful here. We need a separation of rhythm flower. Okay, we are here. Okay. Pituitary, please. Okay. Other please. You know very well. Inside over here, inside over here, inside over here. This is the code. Can you see here? This is code. So you have to know. Please. And we can go, because here in the middle, we can go more laterally. Yeah, so I want to go. Superficial bone first, like this. Superficial bone like this. And move to the more deeper area, Move to the more deep area like this. Okay, and the more deep area like this. We are going to more deep area. The support of SAP is the most important thing, okay? Remember it. We can find the middle wall of SAP from the distal lamina. This is the distal lamina. SAP and distal lamina is one body. So you can find the SAP from the distal lamina. Okay, so
what is the size of the diamond ball you are using?
Yeah, there is no available to this. We have only one day. But sometimes side cutting such as matchstick is very useful. But we have some limitation for the instrument. But I can do it. I am doing my best. So I believe the result of my surgery must be good. So believe me. Please believe me. Now just before I find the pedicle, this is the medullary bone of the pedicle. Do you understand? So here is the medial wall of the pedicle. So lateral part of the medial pedicle. Here is the safety zone. So we can become playable. Like this. Like this. Okay. We can go cranially like this. I need a new lever. Change it. Okay. Okay. And here is this lamina. We are going to here. Like this. Over the experience of 112 cases with bipolar, I don't have experience of post-operative weakness. But nearly all my patients, their symptoms is improved immediately. So, progression. With this method, I believe we can treat progression. Cutting. Okay, stop. Cutting. Stop. I don't know why you're so quiet. Okay. Please. For the cold level decompression, you can make your bone into the pink color, okay? Make it transparent. Change it. Whether you like umbrella, please change it frequently, new one, okay? It is not working really. No, same deliver. Okay, you do well though. You understand? Okay, you are here also. are going to close your like this. Okay. Bone. Okay. We are here also. We are here also. Okay, be careful. If you use a different types of deliver, your service becomes more faster. I like to use A1C3 cutting ball and the diamond ball. Let's pick, we can use all kinds of this, but yeah, here you can see here you T-level safety, okay. You have to here. You can see the second, this is the second legal problem. Would you take this? Really too big. Smaller one. You do short one faster. It's good. I need a small head. It's head too big, okay? Small head, put it for that, please. If you have, okay. No, I don't like this one. Okay. Okay, three references. We are here. So there is no division between bone and dura. So here you enter the bone, we can find the spinal cord here. So release and make it like this. Really French.
Yeah, very nice, sir. So, Professor Park.
Yes, sir.
I mean, meanwhile, as we will start the proceeding for the meet the master sessions, and we'll keep observing you on the central screen, and if anything important, we'll come back to you.
I don't know what they say. They are clearly.
But your surgery will be displayed on the screen.
Yeah, Rajesh, please.
So this finger color, we need here the Peter say. Okay. Reverse. So here is a no compression zone, so you can put your punch into the here. Here is no compression zone. So here is the medial pelvical, and you are here. You cannot put the instrument into the compression area. Only you can put your instrument. Hold this. That's the way. Hold this underscore. Okay. Like this. Hold it. It's okay. So you can separate it here. You can separate it here. 120, very dangerous. You are here. You can see the second YLF here. This is the second YLF, okay? So I am removing. Pituitary. You can touch. because only lift up without compressor, you can lift up the OLF like this.
Yeah, perfect.
So, no compression technique, only lift up, and take it out. This is classified OLF. Clean up this. What they say, they complete the, yeah, this is right here, just before I complete. This is a one-handed surgery. There is some dedication, you understand? So if you can hold my endoscope, I can use the two hands. Okay, try it. You can try it. Show me here. Okay, very nice. Now I'm using two hands. I can decompress here. Okay, very good. We are here. We are near the medial oral pericarp. Okay. Follow me. Punch go. You need punch go. To me, please.
Discussion के लिए उनको
just to see what's going on there.
Thank you.
Yeah, Professor Park.
The three is most important.
Yeah, come back to.
일단 사이드 카팅도 하고 But everybody,
Professor Park.
with me. Yes, yes.
Thank you very much.
Thank you very much for having me here.
Yeah.
Yes. I believe that this conference is successful.
Yeah.
People are different type of cutting there. Not only with the speed of myself to become faster, but I'm very good. I'm very happy because I believe myself is successful. Thank you so much, everyone.
Yeah, you can hear the big round of applause for you.
Thank you, everybody.
Yeah. Yeah, please, like Rajesh, please bring sir here so that we can start the meet the master session.
Okay, as this is opening up,
Yeah.
I thank the organizers, of course, Professor Kale, Professor Dattaraj, and they keep on calling me repeatedly. Whether I'm good enough or not, I don't know. This is the third time I've come to AIIMS to show my work on anterior surgery. And I'm also facing a little problem like Atul. It took some time for people to accept that Atul described posterior C1, C2 fixation. I've been talking about submandibular work since, I think, 2000. My papers are there in Journal of Surgery. Can you hear now? Still more?